Hello everyone, my name is Michael Papazian, and I'll be presenting a case on behalf of the NYU Department of Otolaryngology. In this skull-based oncology case series, we present a sinonasal undifferentiated carcinoma with a failed response to induction chemotherapy. The patient in this case was a 68-year-old male with past medical history of HIV and type 2 diabetes who presented with a right nasal cavity mass. This patient's symptoms were 2 months of nasal congestion with intermittent rhinorrhea. He had no other pertinent past medical history. He had no history of malignancy to the head and neck, no radiation to the head and neck, and a minimal smoking history with no heavy alcohol consumption. On exam, the patient had a clear nasopharynx. He had no cranial nerve deficits or neck masses. On rigid endoscopy performed in the office, a nasal mass was seen in the right nasal cavity, medial to the inferior and middle turbinates. Imaging was performed with both the CT and MRI. CT showed a right sphenoid sinus soft tissue mass with extension to the right nasal cavity, in the left sphenoid sinus, an extension to the cella turcica, while MRI showed the same with extension through the cribriform plate. Images are shown here with the reads of the CT from the radiologist, as well as of the MRI shown here. A biopsy of the mass was obtained and immunohistochemical staining was performed. Results of staining are shown here, and this pattern was consistent with sinonasal undifferentiated carcinoma, or SNUC. A PET scan was performed and was negative for adenopathy or distant metastasis. This gave the cancer a final stage of T4B, N0, M0. This case was presented to a multidisciplinary tumor board, and multiple treatment options were considered, such as definitive chemoradiation therapy, primary surgery followed by adjuvant radiation therapy, or induction chemotherapy, followed by either CRT or surgery, depending on tumor response. The optimal management of SNUC is unknown. Given the rarity of the cancer, prospective trials of treatment methods do not exist. Currently, we rely on evidence from retrospective studies to guide treatment decisions, many of which are small, single-center analyses. What is known from these studies is that treatment with multiple modalities of therapy is superior to treatment with a single therapy. These findings were summarized in a recent meta-analysis by Morand et al., which showed that treatment with a single modality of therapy, such as surgery or radiation therapy alone, was associated with lower survival than treatment that utilized multiple modalities of therapy, such as surgery in conjunction with radiation therapy, chemoradiation therapy, or surgery in addition to chemoradiation therapy. A figure from that paper is shown here. However, the ideal timing and sequence of these treatments is still unknown. Given the demonstrated advantage of multimodality therapy for SNUC, the standard treatment typically employed is craniofacial resection followed by radiation therapy or chemoradiation therapy. When surgery is performed, either an open or endoscopic approach can be utilized. However, the role of primary surgery is limited, as many patients are unresectable at presentation given the propensity for SNUC for local invasion and intracranial extension, such as we saw in our patient. According to NCCN guidelines, systemic therapy should routinely be part of the overall treatment for patients with SNUC, as SNUCs are known to be chemosensitive. With this in mind, there has been growing evidence for the use of induction chemotherapy in the treatment of SNUC, and it has been suggested that the response of the tumor to induction chemotherapy can guide the choice of subsequent therapy. This notion originated from a study by Amit et al. Out of MD Anderson in 2019. This was a retrospective study in which all patients with SNUC initially received induction chemotherapy. The subsequent choice of therapy was guided by how the patient responded to induction chemo. The basic study design was as follows. If patients had a partial or complete response to induction chemo, they were treated with CRT or surgery. Similarly, if patients did not have a response or even had progression of disease following induction chemotherapy, they were also treated with CRT or surgery. The primary outcome was disease-free survival at 5 years, and this was compared across the 4 groups. The induction chemotherapy regimen they used in their study was cisplatin plus etoposide or docetaxel. The primary results of this study are shown here. In patients who responded to induction chemotherapy or had a partial response, those who were treated with CRT had higher rates of survival than patients treated with surgery. On the other hand, in patients who did not respond to induction chemotherapy or who progressed, those who were treated with surgery had higher rates of survival than patients treated with CRT. This would suggest that the ideal paradigm for SNUC treatment would be to treat patients who respond to induction chemotherapy with CRT and to treat those who do not respond to induction chemotherapy with surgery. Since chemotherapy and radiation therapy are a common feature of many of the treatment paradigms we have discussed, it's helpful to review what the normal treatment regimens are when these therapies are utilized. For chemotherapy, common agents used for the treatment of SNUC are a combination of cisplatin and etoposide, 5-fluorouracil alone, or, when used for induction chemotherapy, a combination of cyclophosphamide, doxorubicin, and vincristine. Alternatively, platinum-based therapy alone, such as cisplatin, can be used if CRT is being utilized to reduce toxicity. When radiation therapy is employed, typically the radiation oncologist will aim to administer a dose that is greater than 60 gray over the course of treatment and utilize IMRT, as this has been shown to be associated with improved outcomes. Prior studies have suggested a possible dose relationship between the amount of radiation given and survival in patients with SNUC. When patients present with a clinically negative NEC but locally advanced disease, such as T3, T4 disease, it has been shown in prior studies that elective nodal irradiation may be beneficial, as these patients have a very high likelihood of having local regional recurrence. In considering the possibilities for surgical approach, historically, the open craniofacial resection was the gold standard surgical intervention for all anterior skull-based tumors, such as SNUCs. This approach was first described by Ketchum in 1963, and here are some images from that initial paper. But over recent years, this has been demonstrated to have suboptimal survival rates and very high rates of complications and morbidity for patients. Here are some images of what that approach entails. A more recently introduced approach for anterior skull-based malignancies is transnasal endoscopic resection. Compared to open craniofacial resection, endoscopic approaches have reduced perioperative morbidity and better cosmetic outcomes. When survival differences are compared between patients who have undergone endoscopic resection and open craniofacial resection for anterior skull-based malignancies, there does not appear to be a significant difference with regards to survival. Images here display what the surgeon may see during a transnasal endoscopic approach. As you can see on the right, the panel labeled A shows an anterior skull-based defect after bilateral endoscopic resection, and in panel B, you see the reconstruction with a single sheet of alloderm. So, in revisiting the options that our tumor board were thinking about, we want to review the potential pros and cons of these treatment options. When considering definitive chemoradiation therapy, the advantages are that CRT can be employed in patients with locally advanced disease, where there's little confidence that negative margins can be attained surgically. Similarly, when the tumor is advanced and involving local structures, CRT can preserve organs such as the orbit, which can decrease morbidity. The disadvantages of this approach are that up to 70% of patients with SNUC have viable tumor at surgical resection following CRT, and higher doses of radiation therapy are associated with other complications such as radiation-induced retinopathy and optic neuropathy. So this choice of treatment does come at a cost as well. When considering the approach of surgery followed by adjuvant radiation therapy, which has historically been the standard of care for SNUC, the advantages are that you can use a lower RT dose in the adjuvant setting, which can avoid some of those complications we just went over. When you achieve gross total resection, it's very predictive of local disease control. So if you can attain negative margins, a primary surgical approach can be a good option. And multiple case series have shown that overall survival is higher in patients who receive modalities involving surgical resection as opposed to modalities in which surgery is not included. The disadvantages of this approach are that achieving negative margins in many patients with SNUC is not likely, and proceeding with resection in cases that are likely to have positive margins does not appear to provide survival benefits as opposed to other treatment methods. Similarly, performing a surgery, an extensive surgery at that, could result in postoperative complications, which delays receipt of adjuvant treatment, which may be providing more of the benefit. Finally, considering the approach of induction chemotherapy followed by surgery or CRT, depending on the response, as initially highlighted in the MD Anderson study by Mitt et al. That we went over, The advantages are that this has the potential for organ preservation. The response to induction chemotherapy is prognostic and can help determine the next best step. You can achieve cytoreduction of tumor given the chemo and radiation sensitivity of SNUC, and you can improve surgical margins. Similarly, if disseminated disease is present on diagnosis, this approach can reduce the incidence of distant metastasis. And a con is that you may prolong the treatment period with increased toxicity with this approach. Returning to the patient in this case, we opted for induction chemotherapy as the initial step. The patient was treated with 2 cycles of cisplatin and docetaxel, and we performed a follow-up MRI 2 weeks after the final cycle, which did not show a significant reduction in tumor size. Therefore, this patient would be characterized as a non-responder to induction chemotherapy. Shown here are the MRI images taken 2 weeks after completion of the induction chemotherapy. The tumor appears unchanged from initial imaging, demonstrating that the tumor did not respond to this initial treatment. Following the paradigm outlined by Amit et al. In their study, we opted for an approach of surgery and adjuvant therapy. Definitive CRT was not performed given the non-response to IC. For this patient, an endoscopic craniofacial resection was attempted. The skull base defect was reconstructed by acellular dermal matrix and a nasal septal flap. While gross total resection was achieved, margins were noted to be positive on the brain. Following surgery, post-operative MRI was obtained and is shown here. And what we see are changes compatible with an extensive sinonasal surgery, as well as the reconstruction with enhancement of the flap. The pathology of the tumor that was removed was consistent with sinonasal poorly differentiated carcinoma, and multiple margins were positive for carcinoma. Post-operative CRT was then planned with carboplatin and RT. Unfortunately, this treatment was discontinued before completion of the full course at the patient's request, as they did not tolerate the treatment and received 38 gray and 2 doses of carboplatin. Of note, some recent case reports have demonstrated a role for PD-L1 testing and administration of immunotherapy at this step. Typically, the immunotherapy is given concurrently with radiation. Nine months post-treatment, a surveillance MRI after the incomplete CRT demonstrated persistence of the sinonasal tumor. In the following MRI, you'll see nodular enhancement along the anterior inferior interhemispheric falx and skull base. Here are the MRI images demonstrating persistent disease at the skull base. Tissue biopsy was obtained from the left orbital rim and the left portion of the remaining septum. This biopsy was consistent with SNUC and demonstrated a similar morphologic and immunohistochemical profile to the biopsy discussed previously. For this patient, repeat surgery was not recommended given that the patient had received adjuvant CRT and there was a high likelihood of complications with repeat surgery. The patient was advised at this time to discuss palliative options. Again, we did not perform genetic testing in this case, but there is emerging evidence for receipt of immunotherapy if patient is PD-L1 positive when conventional treatments have failed. This is a topic that deserves additional research attention in the coming years. Local recurrence is a common feature of SNUC, particularly when this disease presents at an advanced stage, as with our patient. There are currently no formal recommendations for how to manage these patients once recurrence does occur. At this stage, typically symptom management and palliation become the primary goals of treatment. To review the key points discussed during this case, multimodality therapy is associated with improved survival compared to single modality therapy for SNUC. Surgery followed by adjuvant radiation, with or without chemotherapy, has historically been the standard treatment for SNUC. However, induction chemotherapy is gaining favor as the initial step in treatment, as induction chemotherapy has the advantage of reducing risk of distant metastasis that may be present on diagnosis, It can predict radiation sensitivity of the tumor and can help guide choice of optimal therapy as outlined in the study by Amit et al. Those results are again summarized here, where patients with a favorable response to induction chemotherapy had the highest survival when treated with CRT as compared to surgery, whereas patients who failed to achieve a favorable response to induction chemotherapy had the highest survival when treated with surgery, followed by adjuvant therapy. If possible, these results should be validated in a prospective clinical trial. Given the rare nature of this disease, these will likely have to be multi-institutional studies. Finally, the role of immunotherapy is expanding in the treatment of SNUC and warrants further investigation. The sources utilized in compiling this literature review are included here, with the Amit et al. Study highlighted at the top. Some other single institution series and multi-institution studies are shown here. Thank you very much for your attention, and I appreciate your time.